a lot of the problems that people experience living with diabetes really are from a mental health perspective. The daily burden, the challenges, the unexpected impact on other aspects of life.
Welcome to Startup Health TV, where we celebrate the entrepreneurs and the innovators who are transforming health. I'm Logan Plaster. We're here on the floor of the American Diabetes Association annual conference, and I'm with Katharine Barnard-Kelly, the CEO and co-founder of Spotlight AQ. Kath, great to see you.
Hi, thanks very much, Logan.
It was very cool to see you last night on the Innovation Challenge stage. Out of more than 50 startups that applied, there were 5 finalists, and you were chosen as one of the 3 winners. So what do you think it was about Spotlight AQ and your presentation that really connected with people?
Yeah, we were really excited, actually. I think it was because we do something completely different that's completely necessary, but has been difficult to achieve so far. So I think that we're approaching the problem from a different angle was why they kind of shortlisted us and saw some benefits and some.
Yeah, well, that's a great segue into what is the challenge. I know it has to do with really the patient-provider encounter. So start by telling me the current state, particularly with someone with T1D, type 1 diabetes, comes to their provider. Paint me a picture of it and tell me why it's broken right now.
Yeah, so even though we're trying to move more towards a physical and mental health approach, the reality is that all of the healthcare providers and the structures are really rooted in the medical model of healthcare, the physical health priority. And the challenge is that's great for acute health problems. It is completely poorly fitting to anybody with a long-term condition such as diabetes.
What do you mean by that? What do you mean by sort of changing the sort of mental health underpinning or focus versus a medical focus?
So whereas we focus currently on physical outcomes like glycemia, we look at cardiovascular risk, for example, actually a lot of the problems that people experience living with diabetes really are from a mental health perspective. The daily burden, the challenges, the unexpected impact on other aspects of life. You know, if it was just about maths and insulin dosing, then it would be easier, but it's not.
Can you give me an example?
Yeah, so for example, stigma. Living with diabetes weirdly invites other people to believe that you are somehow less deserving of healthcare, or that it's your fault, for example, you know, and if you just moved more and ate less, maybe. And it's like, okay,
you just feel a little lesser than. You have this disease, it kind of it burdens you.
Yeah, so take COVID, for example. People with diabetes felt expendable because others in society are like, well, why can't they just stay inside? Why do I have to stay inside? If they're vulnerable, why can't they stay inside?
Okay, so how do you want to change that interaction? So you've got physicians dealing with patients and thinking primarily in a medical, data-driven, let's get your glycemic numbers here, and they're not maybe seeing the whole person. So, and they're overburdened, they're overworked. So how do you switch that paradigm?
Yes, we come at it from a completely different approach in that we look at a person's lived experience first, and then we look at the impact of diabetes and diabetes management on that lived experience, on that quality of life. So somebody is only able to achieve optimal glycemia if you're able to fit it into your everyday living. So we ask people in an AI kind of driven algorithmic questionnaire, tell me about your life. Tell me about things that matter to you. Psychology, mental well-being, social environments, skills gaps potentially, and therapy. How was that therapy impact on your life? And when we know that, then we can start from there and offer solutions that really meet that unmet need.
Okay, so I am getting ready for my appointment with my primary care physician or endocrinologist. And before the appointment, I get a survey. It's driven by this algorithm that you've developed that helps kind of flesh out who I am more fully. This is what I'm understanding. Mm-hmm. Is it challenging to get folks to fill out a survey?
No, it isn't, because we're asking about you. Your life, your lived experience. Tell me about you. Tell me how we can help you. So actually people have been really responsive to it. And what happens is it takes 3 minutes to answer the questionnaire. You're immediately presented with your results in a kind of bubble graph. So the bigger the bubble, the bigger the problem. And that's often really surprising and shocking for people because they look at it and they go, oh my goodness, that's me. That's it. That's exactly it. Whereas currently they come to clinic and we say, how can we help you? And they go, I don't know. This is a closed question, you know?
When you say the bigger the bubble, what is it really describing? Is it saying like, look, I have anxiety around my home life? Like, what are we seeing in the bubble?
So it can be anything. There's a huge database of questions about lived experience. So for example, it could be, my work colleagues really don't understand how hard it is to live with diabetes. Like, my family really don't give me the space that I need to manage my diabetes. It can be with type 2 diabetes, it can be, we don't eat healthily at home. How can I eat more healthily? If type 1 diabetes, it can be things like, how do I manage exercise? I'm worried that if I go to the gym, I'm going to go low and I won't know what to do. Those kind of questions.
Okay, so you have a SMART survey. The patient goes through it. Now that's presented to the provider. What's that experience like?
Yeah, so for the provider, it's really insightful because they know the level of anxiety or not that their patient is experiencing, the urgency with which that unmet need needs to be met, and also
the size of the bubble.
Yeah, exactly. Also, what they have solutions to meet every unmet need. So what they can do is they can truly understand the person sat in front of them, and they can be confident and competent in providing collaborative solutions to really meet that person's need.
So do they get sort of a profile, a printout, kind of however it looks of, look, here's the bubble, here's the challenge, and here, based on our research, here are some things you could say, do, some treatment pathways that you could present to them, sort of like suggestions?
That's exactly it. They see the bubble graph, and for every unmet need, there are 2 or 3 safe evidence-based resources in different formats, not all like leaflets, or we have videos, we have all sorts of different pathways that you can say, how about we try this? And the patient can say, oh yeah, but there's choices. So it's always collaborative and solution focused.
There was a question in the Innovation Challenge about sort of the simplicity of this, a survey plus suggestions. How do you see technology playing into this, and kind of also what's the moat around it for other people who might compete with you?
Yeah, for sure. So, like I said yesterday, psychology is the study of the glaringly obvious, It is simple. It is. One of the problems we have had with trying to address mental health in diabetes routine visits up to now is there's always a perception there's not enough time. Well, we shorten visit lengths. But also, when you give people questionnaires ordinarily, we're presenting problems, we're identifying problems and challenges, but we're not giving healthcare providers or people with diabetes solutions. What we're saying is, these are the challenges, use your expertise. But they're rooted in the medical model of healthcare. They're not rooted in mental health. So that's why it works. So we identify challenges and we identify solutions that might work, and it does. So we are going through the 510K FDA approval process at the moment. We are very evidence-based and theory-driven. We have a mountain of clinical trial research across real-world evaluations. We already have validated successful measures in type 1, type 2, adults with obesity, children and parents, and we add value by bringing on other long-term conditions. So particularly for primary care, we bring in cardiovascular disease, we bring in COPD, IBD. So those comorbidities, they merge in the questionnaire, and you're able to really tailor the visit to the patient's needs.
Awesome. What are you most excited about for the next, say, 6 to 12 months?
Gosh, so we are doing some research with people with underserved populations across Latin America. We have a randomized controlled trial that was funded by Breakthrough Type 1 Diabetes ongoing in North America with children and young adults. We've got pilots and a closed market launch with key opinion leaders. So we've got all this cool, fun stuff happening, and we're going to bring it to market and commercialize and hopefully change the way we deliver healthcare for the better.
Amazing. Kath, thank you for stopping by, and congratulations on the win last night, and we'll be watching you for the next year.